本次会议即将开始，请您尽快就座，并将手机等通讯设备关闭或置于静音状态。谢谢您的合作。
Ladies and gentlemen, the event will begin shortly. Can we please ask for you to kindly take your seats? We would like to remind you again to switch off all mobile phones and put electronic devices to silent mode. Thank you for your cooperation.
Dear all ladies and gentlemen, friends and colleagues, both on-site and online, good afternoon. Welcome to the Renji Hospital, Shanghai Jiaotong University School of Medicine, the Nizam's Institute of Medical Science, the first conference of the One-to-One project. I'm Flora from Jiaotong Biomedical, responsible for the medical and the marketing affairs. Today, I'm very proud to announce that 2 authoritative hospitals from China and India have joined into the One-to-One project, with a new academic collaboration between the Renji Hospital and the Nizam's Institute of Medical Sciences. By joining hands, closer international communications and medical information exchange on hemoperfusion are expected. Here, I'm very honored to introduce the special guest of today's conference. In the main meeting room, we have Professor Zhao Huini, the Chief Physician of Nephrology Department, Doctoral Supervisor and the Director of Internal Medicine Department, Renji Hospital. Welcome, Professor Ni. And we also have Professor Le Yigu, the Director of Nephrology Department, Chief Physician and the Doctoral Supervisor of Renji Hospital. Welcome, Professor Gu. Also, we have Professor Renhua Lu, the Deputy Chief Physician of Nephrology Department, Renji Hospital. Welcome, Professor Lu. And we have Dr. Zhenzhe Yu, Attending Physician of the Department of Nephrology of Renji Hospital. Welcome, Dr. Yu. For the online panelists, we have Professor Sri Bhusham Raju, who is the head of Department of Nephrology at the Nizam's Institute of Medical Sciences. Welcome, Professor Sri Bhusham Raju.
Hello, hello. Good morning, everyone. Good morning, everyone. Namaste.
Okay, thank you very much. Thank you all for attending today's conference and also being supportive of the health science medicine. Please give me your warmest welcome to them. First of all, please allow me to invite Professor Zhao Huini, the chair of today, to give us an opening address. Professor Zhao Huini, who is the Chief Physician of Nephrology Department, Doctoral Supervisor and the Director of Internal Medicine Department, Renji Hospital. Professor Ni served as a member of many organizations, including the Blood Purification Branch of Chinese Hospital Management Association, Shanghai Society of Integrated Traditional Chinese and Western Medicine Nephrology, etc. Welcome, Professor Ni.
Dear Professor, distinguished guests and old friends, good afternoon. On behalf of the conference, I would like to take this opportunity to extend a warm welcome and sincere gratitude to all the guests for attending the Renji Hospital, Shanghai Jiaotong University School of Medicine, Nizam's Institute of Medical Science, first conference of One-to-One project. With guidance of the Belt and Road Initiative, we will build up a wonderful platform for local and international nephrologists participation, which all of you an unforgettable and perfect experience here. Since the 20th century, with the breakthrough of modern science and technology, medical technology has achieved unprecedented rapid development, and most diseases have been effectively controlled or cured. The average human lifespan have gradually increased. However, in recent years, the incidence of chronic kidney disease and end-stage renal disease is still on a rise trend worldwide. According to the latest data published by the Lancet, the prevalence of CKD is about 9%, and the number of patients with chronic kidney disease reached about 700 million in 2007 worldwide, including about 3 million patients received dialysis. CKD and its cardiovascular deaths is the 12th leading cause of the deaths worldwide, which has become a fatal public health problem. 121 International Academic Exchange Project hold concept of exchange, cooperation, and a win-to-win situation. It aims to build a comprehensive and multi-level international academic exchange and cooperation platform in the field of the chronic kidney disease and ESRD. It was also carry out in-depth cooperation in CKD and ESRD screen diagnosis and the renal replacement therapy. At present, several local and international hospitals have cooperated friendly and deeply. In the future, more countries and hospitals will participate in the project for improvement in the field of CKD prevention and treatment. This conference will promote academic exchange between China and India, Renji Hospital and the Nizam's Institute of Medical Science through high-quality academic activities. It will improve the quality of dialysis and benefit chronic kidney disease and ESRD patients. Wish all of you an unforgettable and perfect experience here. Thank you.
Thank you very much. Thank you, Professor Ni, for a great address. Next, I would like to invite our special guest, Professor Claudio Ronco, the Director of Department of Nephrology at St. Bartolo Hospital of Italy, to give his valuable perspective on both the one-to-one project and the conference. Please.
Dear friends, I really would like to congratulate Jiaotong company from China for the one-to-one project on Transnational Hospital Unite. I think this is a wonderful initiative to exchange information in which one Chinese hospital will have a pair in countries to focus on patient care and living quality. I think sharing clinical experience improve precision medicine and will contribute to global healthcare improvement in patient therapies. Also, there will be a possibility to share information about novel therapies and novel possibilities to treat the patients that require special treatments. I think that having a so-called borderless communication for a better human life represent a wonderful initiative. And once again, I would like to congratulate Jiaotong company for having instituted this wonderful academic project. This is Claudio Ronco from Vicenza, Italy, and I'm very proud to announce that this project will probably be also picked up by my hospital.
Thank you, Professor Ronco, for his kind wishes and encouragement. Following, please allow me to introduce another special guest from the Nizam's Institute of Medical Sciences, Professor Sri Bhushan Raju. Professor Sri Bhushan Raju is an expert in nephrology of the Nizam's Institute of Medical Sciences. He owns numbers of awards and recognitions, including the Corona Warrior by India Medical Association and the fellowship of numerous societies. Welcome Professor Sri Bhushan Raju to give us some of his opinions on this event. Welcome.
Good morning, everyone. And I'm Dr. Sri Bhushan Raju, Professor and Head of Nephrology at Nizam Institute of Medical Sciences. And I'm proud to be a part of this particular prestigious program, a one-to-one project between the Renji Hospital, Shanghai, Jiaotong University School of Medicine versus the Nizam Institute of Medical Sciences, Hyderabad, India. And it is a very great opportunity for me and for my institute and for my department also to learn a lot from the great and the legendary people in the nephrology department, especially the Claudio Ronco. And probably there's no nephrologist in the world who doesn't know the name of Claudio Ronco as far as a great achievement and contribution to acute kidney injury and the management of therapies related to acute kidney injury is concerned. And I feel proud to be a part of this particular prestigious program from this part of India. And we all know that there's the blood is an essential component of human life. And probably the statement also, the quotation also, I would like to quote the quotation that the blood is the wheel of the history. So in the similar way, the human being also is flooded with so many miscreants in the blood, either the immunological or infectious agents. And especially when the organ dysfunction takes place, something like a urea creatinine like substances when the kidney fails, or the bilirubin like substances when the liver fails. And these kind of substances should be removed with extracorporeal therapy. And nephrologist is the one who is supposed to look after these patients as far as the extracorporeal therapy is concerned. And this particular project between these particular prestigious institutes, one from China and from India, I feel proud to be part of this institute. And I thank the organizers for this particular program for giving this opportunity. And also I thank one and all to be part of this particular program. And thank you very much.
Thank you. Thank you, Professor Sri Bhushan Raju, for a great address. Okay, now I believe all of you are very curious about the one-to-one project. Please give me your eye now and enjoy the following videos.
Since the 20th century, with the breakthrough of modern science and technology, medical technology has achieved unprecedented rapid development. Most diseases have been effectively controlled and cured, and the average lifespan of humans has gradually increased. However, in recent years, the incidence of chronic kidney disease and end-stage renal disease in the world is increasing year by year. According to the latest research data published by The Lancet in 2020, the number of patients with CKD in the world reached 697.5 million in 2017, accounting for 9.1% of the world's population, including 3.14 million dialysis patients and 840,000 kidney transplant patients. A total of 2.6 million deaths due to CKD and cardiovascular diseases caused by CKD in 2017, accounting for 4.6% of the world's total deaths. And it is the 12th leading cause of death nationwide. CKD and ESRD have become a public health problem that seriously endangers human health worldwide. One-to-One International Academic Exchange Project is uphold the concept of exchange, cooperation, and win-win. to build a comprehensive and multi-level international academic exchange and cooperation platform in the field of CKD and ESRD, and carry out in-depth exchanges and cooperation in CKD and ESRD screening, diagnosis, and renal replacement therapy to promote the diagnosis and treatment of chronic kidney disease jointly, and ultimately benefit the majority of patients. At present, Sichuan Provincial People's Hospital, Zhejiang Provincial People's Hospital, Zhongde Hospital Southeast University, Renji Hospital Shanghai Jiaotong University School of Medicine, the second Xiangya Hospital of Central South University, the first affiliated hospital of Sun Yat-sen University, etc., have respectively reached friendly cooperative relations with Philippines National Kidney and Transplant Institute, the Nairobi Hospital of Kenya, Nizam's Institute of Medical Sciences of India, the United Arab Emirates, and other hospitals and countries. In the future, more countries and hospitals will participate in the project to jointly improve the prevention and treatment of global chronic kidney disease.
It is excited that the collaboration between Renji Hospital, Shanghai Jiaotong University School of Medicine, the Nizam's Institute of Medical Sciences will be set up from today. In order to commemorate this great cooperation, please allow me to invite experts to initiate the launching ceremony. May I have our star columns now? Now, please allow me to invite Professor Ni, Professor Gu, Professor Lu, Dr. Fang, and Dr. Zhang to step in front of the stage, in front of the starting column. Professor Sri Bhushan Raju, please join with us virtually. Please put the hand in front of the starting column. 请现场的各位跟我一起倒数。5, 4, 3, 2, 1. Congratulations that the one-to-one project between Renji Hospital and the Nizam's Institute of Medical Sciences is now initiated. Thank you. Thank you. Here, to celebrate this great news and to memorize the cooperation, Jeffra made mementos for both hospitals. Now, please allow me to invite Professor Ni and Mrs. Han to step on the stage to join with me and give away the memento of this academic collaboration. Please. Congratulations. Unfortunately, due to the COVID-19, international traveling is not allowed. We have sent out the memento by international delivery to Professor Sri Bhushan Raju, and it will be expected within a few days. Now, with the witness of all of you, it's my honor here to announce the opening ceremony is now finished. Next, let me invite Professor Ni to be as the moderator of the webinar. Thank you.
Dear Professor, distinguished guests, and all friends, firstly, let's invite Professor Cerebuzan Raju to give us an introduction of Nizam's Institute of Medical Science and the Department of Nephrology. Professor Raju, please.
Yeah, thank you very much. I hope all of you are able to listen, and we'll try to go ahead now with the program. And Mr. Arunan, can you please share the slides?
Great.
Yes, yes. Go back, go up, go up. Yes. So thank you all for giving this opportunity for the one-to-one project between Renji Hospital, Shanghai University School of Medicine versus Nizam's Institute of Medical Sciences, Hyderabad, India. The next. So this India is second largest country, most populous country after China. You know that. And our state of Telangana is a part of southern part of India, and it has got almost nearly 30 districts. And this is the center. This is a place called Hyderabad, and which is the place of our institute, and this is called Telangana in the country India. Hyderabad is the 6th largest city and 4th most populous city of India. And it harbors nearly 1 crore population. And this is fastest growing city in India and one of the biggest metropolitan of South India. And it is probably, we can call it as the most happening city in India, most happening city as well of all activities, political, administrative, technical, industrial, and so many, including pharma and including medical. It is a medical hub in southern part of India, and it is very well connected to the rest of the state, country, as well as the entire world. And it is connected to every continent in the world. And with an expected GDP of around $201 billion by 2035, Hyderabad may be one of the leading growth driver, not only in India, but also in the globe. So when coming to Nizam's Institute of Medical Sciences, Hyderabad, it is actually, we were part of a kingdom of Nizams before independence of India. And we continue to be like that for a few more years, even after the independence of India. So the erstwhile king called Nizam had its own vision, and he wanted a separate, unique hospital for every part of medicine that time only. We had a separate hospital for the general diseases. We had hospital only for the sake of pyrexia. That we had hospital only for the children. And we had a unique hospital for mental diseases. We had a unique hospital for chest disorders. We had a unique hospital only for the pregnancies and its complications. Similarly, once upon a time, he thought that he should have an orthopedic hospital. So in that way, he started orthopedic hospital. This is the orthopedic hospitals to start with. And it was the foundation was laid down by the former finance minister who became Prime Minister of India later. In 1961, this particular building was laid down. And then the Nizam's Institute of Medical Sciences, Hyderabad. This was actually started in 1961 as a charitable trust hospital with only one specialty called orthopedic hospital. And with a 55 lakh given by Government of India, the construction was started after foundation stone laid by late Sri Morarji Desai. Morarji Desai was the finance minister that time who became the Prime Minister in 1977 of India. The Princess of Beirur, Derushavar Sultan, in 22nd December 1964 formally inaugurated this facility to the public. Next. No, he will change. No? The trust handed over the hospital to the government of Andhra Pradesh, which is again a state in India, on the 13th February 1976 under a 99-year lease agreement. The hospital was renamed afterwards as Nizam's Institute of Orthopedics and Specialities. Finally, the Nizam's Institute of Orthopedic and Specialty became Nizam's Institute of Medical Sciences from 18th June 1989 with the NIMS Act, which was passed by the local assembly as Nizam's Institute of Medical Sciences as a medical university, governed by the government of Telangana, which is the local government. So, yes. And this is the old building, which is actually initially inaugurated in 1961. Then, next. And this is the Millennium Block, which is constructed in the year 2000 to accommodate neurological and cardiac sciences. This is the latest building inaugurated around 5 to 7 years back with a huge funding from Government of India as a part of Prime Minister's Swasthya Suraksha Yojana, which is almost nearly 120 crores of rupees donated for this particular building, which harbors this particular trauma block, which takes care of the people with the trauma. And this particular building here takes care of the super specialty services that includes the cardiac and other surgical services. And this is another view of the building from outside, which is a build-up area of around 4 lakh square feet. And almost this particular building alone harbors around 500 beds. It can accommodate 500 patients easily. And coming to our own Department of Nephrology. It was started in 1988. It was a subsidiary branch of Internal Medicine Department initially to start with. Then the Department of Nephrology bifurcated to a special unique department as nephrology in 1988, and it caters to all the patients from not only from the both Telugu states, especially in South India, but several other states which are there in South India. One of the biggest departments of nephrology in India, with a 6 faculty, 8 nephrology fellows recruited into the program of academic program called a DM program every year, and we have 2 PhD fellows every year to be taken, and we train almost nearly 40 technicians every year also, who are dialysis technicians other than the peritoneal dialysis technicians. And almost we get around 120 to 150 patients every day. It comes to around 37,000 patients as outpatient visits. And when you have inpatient also, it is one of the largest in the country with the 85 general ward beds and another 40 beds given to the private patients who are affordable, and which is not so par with the corporate hospitals, but being a government hospital, despite that we charge some of the patients and who can be accommodated in private hospitals, which are almost 40 beds under our nephrology department alone. And we have an intensive care which is specially run by us, the Department of Nephrology, called Acute Kidney Care Unit, which has got 12 bedded, and we have a kidney transplantation unit which is 8 bedded. And we have a hemodialysis unit, which is almost nearly more than 3 decades. And we have 3 units, which is in the ground floor with the 29 beds, 29 hemodialysis missions, and a unit 2 with 9 missions, which are specially catering to either hepatitis B or hepatitis C. And we have one more program, and the 3rd unit of a dialysis unit has got a 16 hemodialysis missions. And the periphery, we have got another hemodialysis missions, which are 6 in number. In fact, we used to have around 70 to 80, but unfortunately in the recent times with the lack of space, we have come down and we are unable to accommodate more and more patients. We have a new program called hub and spoke model, with which we are shifting the patients of hemodialysis to the periphery centers rather than accommodating everyone in our own institute. This is called hub and spoke model. I will be telling about that later. And this is our ground floor hemodialysis unit, which harbors around 26 patients. Next. This is our exclusive hepatitis C and hepatitis B isolation area for the hemodialysis patients. We don't do dialysis for the HIV patients. Only hepatitis B and hepatitis C we cater to. And this is our 2nd floor. This is our oldest dialysis unit, which harbors almost nearly 25 to 30. But many of the beds are vacant now. We are supposed to get more and more missions, which can accommodate easily another 40 beds. And as far as our services, the Department of Nephrology is concerned. Next. So this is how the number of OPD patients have been escalating since 2010. This is the progress report of our own for the past nearly 10 years. And probably there may be a slight dip during this 2020 because of the COVID infection. But otherwise, this is gradually escalating from 18,000 in 2010 to almost nearly 38,000 in 2019. And as far as the inpatient number is concerned, we had almost near 2,300 in 2010 and almost doubled and tripled up to more than 8,000 cases admitted into our hospital under Department of Nephrology in 2019. And as far as the number of hemodialysis sessions is concerned, we used to have around 15,000, but as we increased our number of dialysis missions, we came up to almost nearly 40,000 dialysis sessions per year in 2019. We have one of the very active peritoneal dialysis programs in our country, and we have been doing a lot of CAPDs right from the beginning, and it started almost nearly 15 to 20 years back. And though the number was actually initially looking low, but we started escalating our number, and it was around less than 50 in 2010 to almost nearly 140 in 2019. And we do all the procedures as a part of internal intervention nephrology, the IJV, internal jugular vein cannulations and femoral vein cannulations here. And we have a both practice of jugular vein cannulations predominantly when compared to the femoral. We try to avoid femoral vein cannulations because our center is the one which is catering to all the patients for kidney transplantations in this part of the country. So we don't really cannulate every patient with a femoral vein unless really indicated, unless it's an emergency. So we try to go with internal jugular vein catheterization. This is what shows very clearly that we depend mostly on the internal jugular vein cannulation rather than femoral vein. And the number of transplantation also is gradually increasing. It is less than 30 in 2010 and now gradually went up to almost nearly 130 in 2018 and 2019. And we have done less number of transplantations during this year 2020 because of the COVID scenario. Though our hospital has been labeled as the COVID-free hospital by government here locally, but still we have not done many transplants because of the situation prevailing in this part of the country. This is another way of diagnosing the cases by kidney biopsy, and we have been increasing our number of kidney biopsy cases from less than 300 in 2010 to almost nearly 3,000 in 2018 and 19. And this is actually 1,300 almost nearly in 2018 and 19. And this is a marvelous number. And this is definitely less than what we routinely do because good number of the cases we tend not to charge the patient also. Those things will not be entered in the software. So this is the minimum number which we have done during this particular period. For almost nearly 1,200 to 1,300 kidney biopsies every year we do. And as far as the special features of extracorporeal therapy, we do plasmapheresis and the hemoperfusion. And the plasmapheresis has come up a bit late, but we were doing very less number of transplantations that time and less number of plasmapheresis also simultaneously. As we increased our number of transplantations and the more and more patients are coming to us with acute rejections, and we started performing more and more as far as the plasmapheresis is concerned. Now from less than 20 in 2010, it's almost come up to less than 400 sessions in 2019. And we have been increasing the number, basically, not only kidney transplantation rejection cases, but also several glomerular diseases where we found that plasmapheresis is of great utility as far as the patient management is concerned. And the present topic today for the hemoperfusion, we have done very less number of hemoperfusion so far. Basically, the indication for us is the poisoning. Though ours is not a general hospital, we have another major general hospitals in city of Hyderabad, where most of the poisoning cases will go there. But we get very frequently the patients with the poisoning, and we have been doing the hemoperfusion on and off. We are doing on an average around 20 to 25 cases per year, and probably will be increasing the number, and also increasing the indications for hemoperfusion in the future. And we are into active research, though we have done a lot of academic research projects. These are some of the major sponsored research projects by the ASLAS. We have completed the first largest by me, and this is the Conivaptan in euvolemic hyponatremia, which was finished in 2003, and which was sponsored by ASLAS. Then Indian Council of Medical Research, which is the prestigious government organization which takes care of the medical research in our country, has actually funded us for the multicentric study to find out the prevalence of chronic kidney disease in adults in urban India population, which was totally sponsored by the ICMR, which is the prestigious government organization. And it has finished its study in 2013, which was basically to find out the prevalence of chronic kidney disease in India from every city. And we, as a principal investigator from Hyderabad, we found that around 6.8% of the population knowingly or unknowingly be having a chronic kidney disease underlying in our people in Hyderabad. And we have done other studies also. Cremzin is an adsorbent which will be given to the patient with a chronic kidney disease, but unfortunately it did not really withstood the test of the time, but we've completely and successfully finished this project in 2012. And we have done other several trials also. And these are the trials which are done through George Clinical Institute, which is a prestigious institute, which is with Oxford University, and George Clinical Trials, Clinical India Limited, which is and under the aegis of George Clinical Trials from Australia and Oxford University. We have done a good number of the studies related to diabetic nephropathy and other studies. This is one prestigious Credence trial, which is published recently, around 1-2 years back, and I am one of the principal investigators of this particular Credence trial. And we have been actively doing the studies related to hyperparathyroidism in chronic kidney disease. This also is finished recently. Next. And several ongoing trials with the George Clinical Institute with IgA nephropathy and erythropoietin therapy and severe hyperphosphatemia and hypertension and various drugs which are related to hypertension management. The next. And there are several phase 2 and phase 3 trials we have been doing, and this is with the thymoglobulin, and this is another trial with in a patient with renal anemia, and this is another trial which is in the process of getting it approved with efficacy of in the various drugs in the renal anemia management. And this is another prestigious trial project which I have been doing with the aldosterone blockade in health improvement evaluation in renal disease achieve trial, which is ongoing now. And this is another trial which is just recently came to a halt, and unfortunately we could not go out with this particular project because of the COVID era. And this recently we were told that they are unable to go out with this particular project to study the natural history of leukocyte chemoattractive factor 2 amyloidosis, the elect mutations in patients with amyloidosis. And another study called Vistera trial, which is international trial by Georgia Clinical Trials, which is a novel drug which is being tested in patients with IgA nephropathy. And next slide. And thank you very much. This is Nizam Student Medical Sciences, and this is the Renji Hospital, Jiaotong University, China. Thank you for the kind attention and patient hearing.
Thank you, Professor Raju. Next, I would like to invite Professor Le Yi Gu to give us an introduction of Renji Hospital and Department of Nephrology. Welcome.
Thank you, Professor Ni. Thank you, Professor Sri Buzan Raju. Good afternoon. It's a very pleasure to introduce Renji Hospital and the Nephrology Department. This is the Paranoma for Renji Hospital East Campus. So the Renji Hospital was founded by Dr. William Lockhart in 1844. He was a missionary from London. Renji Hospital is the first hospital practicing Western medicine in Shanghai, and the second hospital in China. And this the oldest. This is the oldest building have been destroyed, but this building was built in 1932. This building is still being used as the main building in Western campus until now. And that is the photo show the older wards. When I was a resident doctor, I worked in that wards. So until now, Renji Hospital have 4 campuses and research institute. The west campus was located at nearby the Huangpu River, but East Campus is the headquarters for Renji Hospital. The North Campus is a reproductive center, and the South Campus is located at the suburb area. The Shanghai Cancer Institute is a very famous research institute. In our hospital, we have 2,200 beds and more than 4,000 staffs. We have more than 50 clinical departments. In 2019, we served more than 140,000 inpatients and 5.5 million outpatients. We completed almost 130,000 operations. So the Shanghai government surveyed 54 types of key diseases, 22 of which in top 3 and 40 in top 5 for Renji Hospital. So we completed the operation for new cancer cases is the rank 3rd in Shanghai. So we also have some research platforms. Some is national level, some is city level. Shanghai Cancer Institute was the key laboratory of China, and the WHO collaborating center for research on cancers. We also have key laboratory of Ministry of Health and the research laboratory of State Administration of Traditional Chinese. That's the new building for research. This building was launched in early of 2020. We also have some international joint labs, such as China-Australia for personality immunology. Professor Carola Venusa from Australian National University and Professor Shen Nan from Renji Hospital were the co-director for that lab. That lab was located at the West Campus. So we won a lot of research grants. So some good results had published in top journal like New England, Nature, and so on. Regarding the Nature Index, we also keep top 3 in China. It's fortunately for us, in this year, both fraction count or article count, we ranked the first one, the first in China. We also won a lot of awards from government. So we also perform some international medical education. Ottawa-Shanghai Joint School of Medicine is the only Sino-foreign cooperative project in undergraduate medical education, which approved by the Ministry of Education. So the official enrollment began in 2015. We also have some international student exchange programs. This is the main global partner for us. So next, let me introduce the Nephrology Department. This is the photo for the whole department. I remember it may take in 2014. So Nephrology Department was founded in 1960s. It's one of the earliest renal division in Shanghai. Now we are the national key clinic specialty in nephrology, which was named by Ministry of Health. We performed the first home hemodialysis treatment. So we established the first home hemodialysis center in China. We also be the uremia diagnosis and treatment center for Shanghai Jiaotong University School of Medicine, as well as Shanghai Municipal Center for Peritoneal Dialysis Research. In our department, we have 40 doctors. 8 professors and 6 associate professors. We have more than 60 nurses. There is 3 staffs worked in the lab. So in our department, we have 85 beds. I think it's the same as the Nizam. We admit more than 4,600 patients per year. And we followed over 550 maintenance hemodialysis patients. At the end of 2019, there was 671 patients survived. It's peritoneal dialysis patients. So every year we served more than 144,000 outpatients. In our lab, we perform pathology diagnosis and scientific research. This is the photos for our wards. All of that is nurse stations. So the outpatient number and inpatient number grow very fast. So we performed the first hemodialysis treatment in later 1960s. When during 1997 to 2014, we were the Shanghai Municipal Center for Hemodialysis Quality Control. At that time, we performed the first hemodialysis registering. That's the first in China. The high quality data had been adopted by USRDS in 2007. We also lead the DOPS-4 study in China. The Renji Hemodialysis National CME course was started in 1997. So how about research? We focus some fields about the metabolic profile in different modality of hemodialysis, the mechanism and the preventive therapy on CVD complication and the vascular calcification, as well as biomarker of AKI. We're also interested in some clinical work like comparison of effect of high volume HDF and high flux HD and on patient survival rate, and the multi-center clinical trial to compare the effects of different blood purification models and others. And in 2020, we performed the first home hemodialysis treatment. So we established the first home hemodialysis center and a home dialysis training center in China. So for the PD, the first PD was introduced in Renji in later of 1960s. We published the first PD paper in 1978. The standard the PD program was established in 1985, and the PD data recorder system has been set up since 1994. We also launched the PD National CME course since 1997. This slide shows the new patient and the survivor patient. So the new patient grows stably, but the survivor patient increased very fast. So at the end of these of 2019, there was 671 survived PD patients. So in the research, we focus on the fluid management, nutrition adequacy, and so on. And for the basic science research, we're interested in the peritoneal fibrosis and the water transport and the mesothelial cell apoptosis and so on. So we focus on the preserve peritoneum and prevent complications. So we compare the patient outcome between Canada Center and the Renji Center. We found for the patient survival rate was similar between two centers, but the technique survival rate was higher in Renji Hospital. We also performed a control study to compare the adequacy with the different adequacy with the outcome of PD patients. And we found if the KTV more than 1.7, the survival rate was similar with KTV more than 2. So this data was adopted by the ISPD guideline as the evidence. So until now, we published more than 150 papers, and we also present more than 10 oral presentations in different international congresses. We won the 6th ISPD Young Investigator Grant and so on. So we also get the National Science and Technology Progress Award in 2007. So recently, we advocate some PD patient transfer to the APD. So the APD patient increase is very fast. We hold the first APD CME course in China. We also focus on the new application for APD, especially in urgent start PD program. For the urgent start PD, we conduct a multi-clinical trial on urgent start PD, and we find it's safely and feasible dialysis. So some data had published in some good journal. We are invited to write an article about urgent start PD in 2018 ISPD Asia Pacific chapter. So we also served for a lot of outpatients. We established the cohort of the CKD, diabetic nephropathy, IgA nephropathy, lupus nephritis, and so on. So in the laboratory work, we give the pathology diagnosis. I think in 2020, we make diagnosis for more than 1,000 patients. We also perform a lot of basic science research. So this is a word and some books from our department. And this is many honors. So it's all. Thank you.
Thank you, Professor Gu. Next speaker is Professor Ranko from Wichinta. He has prepared an online lecture about the rationale of X in COVID-19 and experience sharing from Italy. Professor Ranko, please, welcome.
Now, we are coming from the experience of the severe acute respiratory syndrome, which was an atypical pneumonia caused by the SARS coronavirus, appeared for the first time in Guangdong province, that caused from November 2002 to July 2003, more than 8,000 cases and approximately 800 deaths. Since 2004, we have no further information about this. Bats and small mammalians were involved. The Middle East respiratory syndrome called MERS is another disease involved by coronavirus. And at the end of November 2019, a total of 2,500 cases were reported in Middle East, including 858 associated deaths. Majority of cases were reported from Saudi Arabia. I think this was identified for the first time in 2012, and then includes different clinical pictures from asymptomatic disease to an acute respiratory distress syndrome and multiple organ failure. Camels were considered the source of transmission, and droplets were identified as the likely mechanism. We have seen different jump of species for influenza virus, H5N1, H1N1, the swine influenza. And now we are seeing this new devastating epidemic of coronavirus that very likely made the jump from species through a pangolin species to the human being. What is a common observation around the world is a specific type of pneumonia that is not easy to see in other conditions. There are conditions that are non-severe, there are conditions that are severe, but what is striking is very often the quick passage from a condition almost asymptomatic to a very severe dyspnea and a very severe condition just in few hours. We are aware today that the glycoproteins forming the so-called spikes of the coronavirus have the ACE2 receptor as a site for attachment to the human alveolar cells and bronchial cells. And at this point, the entering the virus become the cause of the infection. Now, it is interesting to consider that angiotensin converting enzyme, which is a membrane-bound aminopeptidase that has a vital role in the cardiovascular and immune system, is involved in heart function and development of hypertension, diabetes, and other disease. In addition, this has been identified as a functional receptor for coronavirus. At this point, the infection is triggered by binding of the spike protein of the virus to the ACE2 receptor, which is highly expressed in the heart and lungs. For this reason, I think that it is extremely important to consider patients who are undergoing antihypertensive therapy with ACE inhibitors because they tend to express more ACE2 receptors. And also, it should be considered the important effect that the virus has on the cardiovascular system. As a matter of fact, in this paper, it has been established that a particular attention should be given to cardiovascular protection during treatment for COVID-19. Now, we have, time ago, especially looking at the problem of sepsis, identified how much different organs may interact in the so-called organ crosstalk. There is a physiological transmission of signals between different organs, cardiorenal, hepatorenal, lung and renal, and all these different interaction may lead to a situation of multiple organ dysfunction. At this point, we have also identified the concept of ECOS, which means extracorporeal organ support system. This extracorporeal organ support is provided by different type of circuits, different type of devices, and different types of filters that may go from VV to VA ECMO, oxygenation through a membrane, an extracorporeal membrane, CO2 removal, ultrafiltration for, let's say, support of the heart, CRRT for the therapy that replace renal function, plasma filtration or plasma exchange, hemoperfusion, and we will discuss specifically this today, albumin dialysis, coupled plasma filtration, absorption, and so on. Basically, these therapies are all part of what we call an integrated approach to sepsis. And in this case, it could be an integrated approach to our COVID-19 patients. Because infection that normally with bacteria induce endotoxin, in this case, will have viral particles inducing a specific immune response, both at the organ, tissue and cell level. And at this point, cytokines and chemokines can be somehow part of the so-called cytokine storm that could be partially modulated by specific therapy that we will see in a minute. This may prevent progression towards organ damage, which is normally induced by the effect of chemokines. Now, this is a condition in which the immune system produces a massive activation of the immune system with the extreme release of cytokines and activation of different type of cells of the immune response. Severe complication may be therefore involved in different cytokines from interferon gamma to TNF alpha to interleukin 6, 10, 12, 16, 17, and 18. What is interesting, and Hotchkiss has clearly demonstrated, there might be a counter anti-inflammatory secretion of cytokines that may induce in long term, in some cases, immunoparalysis. What is the organ effect of the cytokine storm? Well, first of all, acute lung injury, that lungs could be an early target and also later on may end up in a fibrotic repair. Shock, the endothelial cells are extremely sensitive to cytokines, and this patient may need the vasopressor. This can be actually the trigger for our therapies because we identify patients that are under need of vasopressor. Altered coagulation, these patients show very often hypercoagulability, and this is one of the aspects that we have seen in almost all the patients. Renal failure may happen. Normally it comes after a while, not as a starting clinical picture. And finally, systemic capillary leak syndrome that show that this patient can only be maintained in hemodynamic support using vasopressors. Interleukin 6 has been considered one of the most important cytokine, and for this reason, we have elucidated the fact that interleukin 6 produced by different B, T cell, macrophages, endothelial cell, mast cell, fibroblast, and others may be overwhelming in concentration in case of patients with severe pulmonary infection by coronavirus. They may be triggered by other cytokines in a kind of vicious circle of amplification of the production and spillover into the circulation. Now, the effects at the clinical level are definitely fever, cough, shortness of breath, myalgia, arthralgias, fatigue, low albumin, elevated CRP, elevated ESR, elevated LDH, ferritin, and interleukin 6. One of the symptoms that has been identified recently is the loss of smelling capacity and the taste capacity. For this reason, different drugs have been tried, including the so-called anti-interleukin 6 drug called tocilizumab. And tocilizumab 4, given at a certain dosage, has been shown to present some results. There are other drugs that have been somehow identified, and recently there is another drug from Japan, Avigan, that has been proposed for treatment. In summary, the cytokine storm in case of coronavirus infection may require an early treatment to block or modulate interleukin 6 and other cytokines to avoid progression towards the organ failure. But the question that we have today is, do we have other options? And other options may come from the analysis of what many years ago we considered the so-called peak concentration hypothesis. After any type of injury or trigger to secretion of cytokines and immune response, there is first a pro-inflammatory response and subsequently an anti-inflammatory response. And as in the paper of Hotchkiss and colleagues, some patients may die because of uncontrollable inflammatory syndrome. Other patients may die because of uncontrollable anti-inflammatory syndrome or immunoparalysis. There seems to be a threshold, and it would be interesting to try to develop a therapy that may cut the peak concentration of these substances. As you can see here, the pro-inflammatory response may end up with the anti-inflammatory response, but survival is only achieved when you maintain a certain equilibrium between the two. Studying the circulating cytokines may not be completely may be misleading, because as it has been shown by the cytokinetic model by Kellum, Rimelet, and others, the circulating level of cytokines may change very rapidly, and there may be a kind of kinetic gradient of concentration between tissues and circulating level in the blood. For this reason, measuring blood level of cytokines may not be accurate and may not tell you the whole story, even if you remove a large amount of cytokines. In this case, in fact, blood purification may act at the blood level, but due to a gradient of cytokines between tissue and the blood, there might be a movement of these substances from the tissue to the blood. This is very important, because also removing from the blood may redirect the response of the immune system to the place where it is highly needed. So the mediator removal, as I mentioned in the past, may not look for a magic bullet. One single drug, one single cytokine may not be the answer. We need a magic shield that provides protection from different types of cytokines. Now, as we have seen for sepsis, when you have COVID infection, the immune response can be overwhelming, and the presence of cytokines can be somehow modulated by different types of extracorporeal therapies. More recently, we have experienced, most of them, hemoperfusion as a way to absorb cytokines during the so-called cytokine storm. Absorption may occur on the surface of specific neutral microporous resins, which are absorbing high amounts of substances. I must remind you that absorption may occur also for other substances like antibiotics. So if you treat a patient, for example, for 3, 4 hours, 6 hours with absorption therapy, you have to deliver antibiotics and other therapies after this therapy to avoid absorption and elimination of the drugs that you are actually delivering. Also, we have recently studied the blood, in blood purification, the biocompatibility of these solvents, which seems to be excellent, avoiding a specific unwanted reaction on the surface. We published recently this paper where we propose the mechanism by which absorption can be beneficial for this patient. And the idea is the following: when viral infection occurs and pneumonia occurs, you might end up with an immune response of pro-inflammatory and anti-inflammatory cytokines. This can be further amplified by the ventilator-induced lung injury and by ECMO in case you're using this. And this may lead actually to endothelial damage, dysfunction, shock, and finally organ failure. Now, if you apply the therapies that we have mentioned before, you may actually do this isolated or in combination with CRRT, and you can actually cut the peaks of both pro and anti-inflammatory mediators exactly in the moment when this is needed. The problem is that because we cannot monitor the cytokines, the system will self-regulate, removing more of the cytokines that have the highest concentration in blood, thus increasing protection of the endothelial level and preventing, if possible, organ support.
Thank you, Professor Ranko. Next, let's invite Professor Lu Renhua to give us a lecture about the progressive in evidence-based medicine of hemoperfusion combined with hemodialysis for ESRD. Welcome.
Distinguished guests, ladies and gentlemen, good afternoon. First of all, I would like to thank the chairman, Professor Ni, for her introduction of mine. I'm Dr. Lu from Department of Nephrology, Renji Hospital, Shanghai Jiaotong University School of Medicine. Today, I would like to talk about progress in evidence-based medicine hemoperfusion combined with hemodialysis in the treatment of end-stage renal disease. Sorry. Sorry for the technical problem. So let's continue. The epidemiological study shows that the number of hemodialysis patients in China is huge and growing rapidly. We can see in this table from 2011 to 2018, the number of dialysis patients and new patients increased year by year. Meanwhile, the number of HD10 kidney transplant patients increased by years. Nevertheless, the number of HD10 peritoneal dialysis reduced year after year. This slide shows the dialysis vintage of patients in China. We can see that from 2011 to 2018, the average dialysis vintage increased year by year. The dialysis vintage of most patients concentrated in 1 to 3 years. Moreover, patients with dialysis vintage of more than 10 years were less, only 5.6 in 2018. We have to admit that there is a still gap in the overall treatment level of hemodialysis in China. This data from USRDS, JSDT, and the CNRDS in 2016. The presence of a dialysis vintage more than 5 years is 15.7 in US, the same as Japan. However, in China is 30%. So what causes the poor prognosis in dialysis patients? Uremic toxin are the cause of high mortality. There are more than 200 toxins in ESRD patients. These toxins can lead to uremia symptoms, structure damage, and dysfunction of cell, tissues, and organs, and also the metabolic disorders. So eliminating the toxins is very, very important for these patients. As we know, according to their molecular weight, uremic toxin can be divided into small molecular toxin, such as urea, phosphate, creatinine, and the middle molecular toxins, such as PTH, beta-2 microglobin, cystatin C, and so on. And also the macromolecular toxins such as interleukin-6, also the TNF-alpha. It is well known that the principle of hemodialysis is diffusion. It can remove the small molecular toxin, but except the protein-bound toxin. The principle of hemofiltration is convection. It can remove the middle and macromolecular toxin. The principle of hemoperfusion is absorption. It can remove all toxins, especially the protein-bound toxin. So compare with the low flux hemodialysis, high flux hemodialysis, and online HDF, the inflammatory factors and other macromolecular toxins, hemoperfusion clearance efficiency is higher. Microinflammatory state is an important risk factor for complications in dialysis patients. We can see that microbiome-derived produce such as TNF-alpha, interleukin-6, can promote EPO resistance, insulin resistance, acute phase response, fat cytokines, oxidative stress, and vascular conservation, and so on. This reference is from Kidney International in 2002. It shows that microinflammatory states increase all-cause mortality and cardiovascular mortality in dialysis patients. And also there are several references demonstrated that interleukin-6 is an independent predictor of mortality in patients with dialysis. In other words, the microinflammatory states increase the risk of death in ESRD patients. So we ask the following scientific questions. Can hemoperfusion combined with hemodialysis increase the elimination of uremic toxins? Can hemoperfusion combined with hemodialysis improve the quality of life of patients? Can hemoperfusion combined with hemodialysis reduce the risk of death? So there are two recent studies in China try to answer these scientific questions. One is a national multi-center RCT research. The number of participated centers is 13,700. The sample number is 440. The follow-up time is 1 year, and the research proposed is to evaluate the efficacy of HA130 hemoperfusion combined hemodialysis in the removal of molecular toxin from maintenance hemodialysis patients and the effect on the quality of life of patients. The other study is from Shanghai, the Shanghai multi-center RCT research. The number of participant center is 30. The number of patients is 1,407. The follow-up time is 2 years, and the research proposed is to evaluate the effect of hemodialysis, hemoperfusion therapy on the survival rate of MHD patients. The name of national study is Hemoperfusion plus Hemodialysis to Improve the Quality of Life in Maintenance Hemodialysis Patients, a prospective randomized controlled multi-center clinical study. Totally 440 maintenance hemodialysis patients were randomized, divided into 4 groups: LHD groups, HHD groups, LHD plus HP groups, and HHD plus HP groups. And the follow-up time is 1 year. This is the study design. The washout period is 8 weeks. In this period, patients received the low flux hemodialysis for 8 weeks. The observation period is 12 months. In this period, data and samples were selected and at the baseline and at the first week of the first day at 3, 6, 12 months after treatment. The evaluation index of toxin removal rate, including PTH, beta-2 microglobin, CRP, and hemocysteine. The evaluation index of living quality is skin inch, use a dose modified inch rating scale, and sleep quality, use Pittsburgh sleep quality assessment form, and appetite is use the assessment scale, and the living quality use the SF36 scale. This is the treatment. In LHD group, they use the low flux dialyzer. Treatment time is for HD for 4 hours, and treatment frequency is 3 times per week. In HHD group, the same as the LHD group. The only difference is use the high flux dialyzer. LHD plus HP group, they use the low flux dialyzer plus the hemodiatoxifier and use the HA130 from Jiaotong company. The treatment time is HD plus HP for 2 hours, and then for HD for 2 hours, 1 time per week. And the other 2 times use the low flux dialyzer to do the HD for 4 hours. And HHD plus HP group is the same as the LHD plus HP groups. The only difference is use a high flux dialyzer. The result, the number of primary screen maintenance hemodialysis is 476, and 36 patients did not conform the inclusion criteria was excluded. Finally, 440 patients was excluded and randomized to 4 groups. The baseline data, including the age, the number of the percent of the male, the dialysis vintage, BMI, blood pressure, and every fistula, percent of every fistula, hemoglobin, albumin, BUN, creatinine, and KT over V were no statistical difference. So the change of the IPTH after treatment, there was no scientific change in the IPTH value in the LHD group and HHD group. The IPTH value in the LHD plus HP group began to decrease significantly after 6 months, while that in the HHD plus HP group decreased significantly after the 12 months. And also after 12 months of treatment, HP significantly increased the IPTH decline rate by 22%. So HHD, the interaction between HHD and HP was not statistically significantly. And let us see the beta-2 microglobin. After treatment, beta-2 microglobin level was significantly increased in the LHD group at 3 months. LHD plus HP group began to decrease significantly at 6 months, while the HHD group and HHD plus HP group began to decrease significantly at 3 months. And also we researched this research to observe the inch scheme. After treatment, the Peritoneal score was significantly increased in the LHD group and HHD group at 12 months. And in the LHD plus HP group and HHD plus HP group were significantly decreased at 3 months. For the adverse event, the safety analysis shows that the adverse events were no statistically difference in 4 groups. So the research conclusion, it was determined that hemoperfusion had the effect of removing PTH and beta-2 microglobin independently of hemodialysis, as well as the effect of improving parameters in patients in order to prevent and cure the complication of dialysis. The suitable treatment mode was established. It was confirmed that low flux hemodialysis combined with hemoperfusion can remove media and macromolecular toxins and improve protiters of patients, which was better than the effect of high flux hemodialysis. So it provides a simple, feasible, and easy to promote blood purification treatment mode without pure water dialysis. This is a Shanghai study. The name of Shanghai study is Efficacy of Hemoperfusion Treatment on Improving the Survival of Maintenance Hemodialysis Patients, randomized open-label parallel group multicenter study. Totally 1,407 patients include randomized into 2 groups. In the control group, the patient number is 703. The blood purification treatment is 2 to 3 times a week, including HD, HF, or HDF. In HDFP group, there are 704 patients. The blood purification treatment is 2 to 3 times a week. They use HP treatment at least once every 2 weeks. This is a study design. In running period, there will be 4 hours. And in this period, the regular blood purification treatment were procedure. In the intervention period, there is 96 weeks. In this period, the sample were collected at baseline and before the first dialysis at week 4, 12, 24, 48, 72, and 96 day of the first visit. The primary endpoint is mortality, including all-cause mortality and cardiovascular mortality. The second endpoint is new or recurrent cardiovascular events, including angina pectoris, myocardial infarction, and severe arrhythmia and heart failure, and so on. This is a result. All-cause mortality. All-cause mortality in HP arm starts to reduce significantly since 24 weeks. At 96 weeks, decreased about 37%. Over time, the mortality gap between the two groups increased gradually. The cardiovascular mortality in HP group was significantly low than that in the control group. Compared with the control group, CV mortality in HP group decreased significantly from the 24 weeks. And after 2 years follow-up, new or recurrent cardiovascular events was significantly higher in the control group than in HP group. For the quality of life, in kidney disease target areas, symptoms and discomfort, cognitive function and social support was significantly better in HP group than in control group. Furthermore, the SF-36 total score was significantly improved in HP group than in control group. And after treatment, the level of IPTH and beta-2 microglobin in the HP group were significantly lower than baseline. The decrease of IPTH and beta-2 mg in HP group was significantly higher than that in control group after 96 weeks of treatment. For the safety, there were no significant difference in blood lutein, liver function, blood lipid, and blood glucose between two groups before and after treatment. So the conclusion, it is clear that hemodialysis combined with HA130 hemoperfusion treatment can reduce all-cause mortality and cardiovascular mortality, as well as new or recurrent cardiovascular events in patients with uremia. And the long-term therapeutic effect is more obvious. It is further confirmed that HA130 hemoperfusion had the effect of reduce the micromolecular toxin like IPTH and beta-2 mg. And it is confirmed that hemodialysis combined with HA130 hemoperfusion can improve the quality of life of patients with uremia. So a lot of reference indicates that clinical benefit of hemoperfusion combined with hemodialysis include improved anemia, improved inflammation, improve the CKD-MBD, and also improve the refractory hypertension, improve the restless leg syndrome, and also improve the insulin resistance or the protect the residual kidney function. So this slide is from our hospital. Just as Professor Gu has just introduced, there are 3 hemodialysis centers in Renji Hospital: East Campus, South Campus, and West Campus. The total number of hemoperfusion cases was more than 2,600 in Renji Hospital in 2019. And the frequency of hemoperfusion is about 4 times a month. In other words, once a week. Based on the combined hemoperfusion therapy in our hospital in 2019, the calcium, phosphorus, and IPTH level were controlled in an ideal range. Moreover, the nutrition status is also maintained at a good level. So based on these RCT studies and clinical experience, in Chinese blood purification standard operates procedure 2020 version, once a week, HA raising hemoperfusion combined with hemodialysis and treat in series for 2 hours, which can significantly increase the clearance rate of serum IPTH and beta-2 microglobin in MHD patients and improve the symptom of itching. So the take-home message, the main purpose of blood purification treatment for uremia patients is to remove the uremic toxins. Hemoperfusion combined hemodialysis can effectively remove medium and large molecular of uremic toxins, such as IPTH and beta-2 microglobin, improve the complications, reduce cardiovascular events, or cause death and cardiovascular mortality. Just as Professor Ronco said, absorption may be the future of the blood purification, especially in the critical care nephrology. Thank you for your attention.
Thank you, Professor Lu. Now we have several time for question. Anyone, please? Any question?
I have a question for the Indian side. Hello, Professor. Professor Siri Bushra Raji. Sorry. Just now in the slides, you introduced your center. I noticed that you said in your center you trained about 40 dialysis technicians in your center. My question is, what do you mean by dialysis technician? What they do?
You're asking.
I mean, because we don't really have dialysis technician in, we do have a hemodialysis technician, but I think in our center we only have 2 or 3 technicians for one dialysis center. So what do you mean by dialysis technician? And you trained 40 dialysis technician per year.
You are asking me?
Yes.
Yes.
Sorry.
Yes. See, we do train the students after their simple graduation who are non-medical people. So we have a medical courses for the super specialty courses like cardiology, neurology, nephrology, which is basically meant for doctors. So we train the students and for the sake of hemodialysis machine management during the dialysis, something like a dialysis nurse, like the way you have a dialysis nurse. We have a training program for the people who are non-medical. It is a non-medical course where we train the boys and the girls who are very young to almost nearly we recruit 40 students per year, and we train them hemodialysis machine management and also patient how to cannulate and how to take care of them during dialysis and how to hook them to the hemodialysis machine, and all these things will be trained. And at the end of 1 year and at the end of 2 years, they'll have an examination. And it is something like the students up to their level only. It is not truly something like a medical course, but it is for the sake of technician course. They are called technicians. Those who look after the patients when their patient is being hooked onto the machine, they are called technicians.
Oh, I see. 就是刚才这位教授的话，他是说我的问题就是说，因为我们好像这个概念当中的就是透析的技术员，可能一个血透中心就1-2个或2-3个最多技术员，但是他会每年要培训40个这个透析的技术员，但是他说他的这边的技术员的话，主要是培训一些非常年轻的，然后他们没有医疗的背景的，然后就是培训他们给病人打针啊、上机器、下机器这种。我理解可能跟我们就是血透的护士做的工作差的不是很多的样子，所以就是然后会给他们一个培训的证书，大概是这个意思。Thank you.
Dear Professor from India, I have a question. I see the introduction of in your hospital for the hemoperfusion. In 1 year, only 20, less than 30 patients to receive the hemoperfusion. But in our hospital, we do the hemoperfusion more than 2,600. So I don't think in this COVID-19 infection these days, do you use the hemoperfusion to save these patients, plus the CRT, or just like Professor Ronco said?
Yeah, in fact, we use the hemoperfusion only for the sake of poisoning cases. The poisoning, which are very special, the pesticide, insecticide, and the weedicide poisonings, and some of the toxins and some of the drug poisonings like carbamazepine poison and other poisonings, we use the hemoperfusion. We don't routinely use it for the sake of patients with the kidney disease and the post patients with the ESRD, and I've seen the indications for you with the uremic toxin removal and all. We don't use the hemoperfusion for that. So hemoperfusion cartridges are only for the poisoning sake we use. And during this particular COVID period, and we have done CRRT, and we have done plasmapheresis for the patients with the COVID infection simultaneously. But we didn't use hemoperfusion at all for any of the patients with the COVID infection so far.
那刚才陆教授的问题呢，就是说，会不会使用这个HP 来治疗一些就像炎症那个细胞炎症因子啊，像 COVID-19 这样子的情况？那么这位教授呢是说，他们这个目前来说不会，他们主要这个 HP 的话都是用在那个药物的急性的这种中毒上面。I have another question from here. Our nursing sister, hemo nurse sister, she's asking. She noticed that your center, as hemo center, is running 7 days, 24
yes,
hours.
Yes.
So how you manage the nurses?
We run 24/7 till Monday to Saturday. Sundays is a holiday. Sunday we don't run. Sunday only emergencies we cater to. But we have several. Every building has got our emergency hemodialysis machine, and intensive care also we got. And most of the intensive cares we got, and almost the surgical intensive care, medical intensive cares, we got a dialysis port where we mobilize the machine and we do the dialysis. We perform the dialysis then and there itself. We don't shift the patient also. And emergency block, the emergency block also has got its own dialysis machines, and we do dialysis then and there itself. We have dialysis machines also at the post-transplant patients with a kidney transplantation unit. So if the cadaver transplantation patient requires dialysis immediately with some delay in the graft function, so we dialyze the patient then and there itself. So we have dialysis machines everywhere, wherever it is required.
那么其实就是说，他这边的透析中心的话，也是就是和我们一样的，就是正常的常规透析的话，还是周一到周六，周日是不做的。然后呢，他们也是就是但是如果有急的情况的话是可以做。还有呢，就是也是像我们其实跟我们这里差不多的，就是在那个移植中心啊，还有在这个外科的 ICU 啊，一些监护室啊什么的地方也是有那个就是血透机器的，如果需要的话也是可以做的。
Any other questions? Yeah, Professor Zhang.
Hello, Professor Srin Burhan Rajan. I'm Dr. Zhang from Renji Hospital. I would like to ask, in your slide, you show that you have a group of renal transplantation patients. The number is increasing these years. I would like to ask, do you do more living donor transplantation, or the donors are deceased donors?
Yes, we have both the programs. We have live related renal transplantation as well as deceased donor transplantation. And we do almost nearly 20% to 25% of our transplant patients are deceased donor. The rest of all are live related donors. Since 2013, our first deceased donor transplantation was in 2002. Then there's for 2 years we have done it. There's a big gap between 2002 to 2013 because of so many social and political issues. And 2013 onwards, we have been doing kidney transplantations with a deceased donor transplantation program, which is separately and exclusively run by government, local government here. So it is being headed by government officials, and they will look after the deceased donor program, and we are part and parcel of that. And we are also major party to that particular program, and we do around 30 to 40 transplantations every year through deceased donor transplantation program. But otherwise ours is a very active live related transplantation program exists in our institute.
Okay, thank you very much. I have another question is that because in our country there is very limited space for our to do more patients with hemodialysis, so it is really a big advantage for you to have so many HD machines, and
Yes.
in our unit we have a big number of PD patients. We have nurses and the doctors to take care of these patients. So how about the PD work in your unit? And also I would like to ask about your country's policy on dialysis. It is PD first, or you don't? Thank you.
Actually, I'll tell you something interesting, that we have an active PD program in the country. The recently government of India has actually taken up giving free peritoneal dialysis fluid bags to the people through a separate program, which will be given to the people of below poverty line. So that we have started. I am the secretary of Peritoneal Dialysis Society of India. So PD is definitely very close to my heart. And definitely being the secretary, even I propagate and I advocate peritoneal dialysis as a first modality. But unfortunately, India, hemodialysis is a free of cost. The people will get a free of cost dialysis anywhere in the country. So our state, in fact, as you are saying that we are luxurious having so many dialysis missions. But we have one more program called Hub and Spoke model. Hub and Spoke model, we cater to all the patients who are there in the periphery centers in various districts. For example, in our own state of Telangana, we have around 44 dialysis centers across the state. 44 dialysis centers across the state. And there are 3 major institutions in this state. Ours is the largest, and we cater to around 22 centers. Another 20 centers are distributed between 2 medical college nephrology departments. So we cater to 22 dialysis centers, and which has got around approximately around 500 to 600 patients. We'll be taking care of them. So we go to their centers on and off, and many patients, they come to us for the medical help frequently. So overall, we are giving dialysis to almost nearly 2,000 patients per month. 2,000 patients per month, we do hemodialysis. So when the hemodialysis is free of cost, many patients would not go for peritoneal dialysis. Despite that, our center is one of the largest in the country, where we do almost nearly 150 new catheter insertions every year. Nearly 150 new catheter insertions is not a simple number, and it is definitely a big number, because every center does, and of which our share is 150 new CAPD catheter insertions every year.
Excuse me, do you mean that for peritoneal dialysis, for patient, it's free? Do you mean?
Yes, the PD fluid bags, the government is going to supply free in some states. It is a central government of India program.
Wow.
And hemodialysis is also free. Hemodialysis is also free for many people. Our state, we provide a free hemodialysis.
Right. 它这边的话就是说，它的这个报销系统好像还是差别很大的。然后他们很多的这个帮的话，它的这个就是腹透的话是免费的，腹透液是免费的。然后那个血透的话也有很多地方是免费的血透。然后还有他就是讲到这个他说他这个帮应该是这个帮吧，就是一个行政区域吧。里面有22个那个血透的中心，但是这个血透中心的话，还有些时候就是对于一些病人来说还是会比较远的，这个通勤的距离还是会比较大的。但是呢，就是说他意思说他们这个中心的话是最大的一个中心，然后每一个中心之间可能也会有一些差异，然后也有一些病人会 会更倾向于到他们这边。
Dear Professor Raju, I have a question I want to ask you. I see in your slide you have a lot of hemodialysis patients, but I want to ask which vascular access will you use and the percent of AV fistula, AVG or cassette. And another question is for the older patient, like more than 70 years old, which first vascular access will you try to use? Thank you.
We have done analysis of our own dialysis patients around 3 years back, which is actually vascular access monitoring program, under which we found that 40% of our patients will be initiated on jugular catheter first, unfortunately, because though we get a very good follow-up of the patients, they don't come to us very early, and even if we tell them to go for a fistula, they do it very, very late. And around 20% of our patients, they come to us very late also. So initially, 40% of the patients will be on jugular catheters, and 60% of the patients would be on fistula. So we have a very good vascular surgery department, and our transplantation surgeons also will do fistulas. So though we cater to the entire state in a state of almost nearly 4 crore population, we do fistulas very frequently, but despite that, only 60% are the fistula first. So unfortunately, 40% of the people will be on either femoral, or predominantly it is the jugular, internal jugular catheter insertion is the first modality or first vascular access for the patient to be initiated on hemodialysis. So this is our analysis, which was done around 2.5 to 3 years back. And not only that, we get a lot of older patients who come in a very sick state. We do permacath as a frequent modality nowadays. So fistulas, we will not be able to make them because of the poor vasculature of the patients, and they are elderly, predominantly they are diabetics. The most common cause of end-stage renal failure in our group of people is diabetes. And they diabetic patients, they constitute around 40% of our ESRD population. So because diabetes is the leading cause, and most of them are elderly population, so we don't get a good vascular access in the form of fistula. So we invariably go for permacath as another modality. And sometimes if there's a problem with the vascular access, then we think in terms of peritoneal dialysis.
Sorry, may I ask what is the percentage of permanent catheter?
It's a 40%.
40%. 40%. Well, but just now you're saying that there's 40% for jugular vascular.
Yeah, jugular, that's 40%, of which permacath is one number.
That's permanent.
Yeah, 60% will be on fistula, 60% fistula. So other 40%, including all permanent jugular catheter, WMN subcutaneous tunnel catheter, and femoral catheter, all these things 40%. And only 60% will be initiated with a fistula. But our aim is to make almost 80 to 84% or 90% with the fistula only. But we will not be able to achieve that because of the social and educational limitations of our patients.
So your target is 60% of AVF.
90%, but it's a 60% now.
Right. 所以他的我们圆圆的问题的话是，就是我们这个通路到底是怎么样的一个比例，什么样的一个情况？然后他这边呢说，就是他们大概是有40%的病人是这样的那个中心导管，然后他说他这个中心导管里面就是包括颈内的和骨的，还有一些是中央静脉，就是永久的那个这个导管，然后剩下的是这个 AV fistula，但是其实他们的这个国家的要求好像是说是60%的 AV fistula，但是其实他们可能60%也不是很到。然后他就讲到这个主要的一个问题，一个是就是来的病人都比较晚，另外一个的话呢也讲到比较这个，因为在他这边的话，糖尿病是一个最明显的最主要的一个 ESRD 的原因，然后这个本身漏管的条件也比较差，所以这个 AV fistula 的这个比例也不是非常高。
Good afternoon, professors from India. I am Jenny from the Nephrology Department. I am the nurse manager and I am interested in peritoneal dialysis. I have some small questions for you. The first one is, do you have nursing specialists for peritoneal dialysis, and what is the nurse-patient ratio, and how do they train the patients, one-on-one or a group training, and where do they train the patient, as inpatient or as outpatient? Thank you.
Yes. So, in fact, I already told you that I'm the secretary of Indian Society of Peritoneal Dialysis. So we would like to spread the peritoneal dialysis as a very good modality across the country. But not many centers are taking the peritoneal dialysis in a serious way. But our center does peritoneal dialysis very seriously. And unfortunately, in India, there's no peritoneal dialysis nurse. We have again peritoneal dialysis coordinator, PDCs, peritoneal dialysis coordinators. The coordinators are non-medical people. Initially, they'll be trained for the peritoneal dialysis program, and who will be training the patients later. First 2 weeks during the hospitalization, after the catheter insertion, and before it starts with their work, starts with the counseling. They'll counsel the patient about PD. Then once catheter is inserted, then they'll be giving the clinical, the flush and other things during the first 2 weeks. And if at all any patient wants to go home early and there's no emergency, these people will go home to the respective patients' houses and they train them. And whenever they get into some problem, first they will be attending the patient at home. Then afterwards, they'll bring the patients to our hospital and we take care of them. And during the hospital also, they'll be coming. So we have in our institute, we have three technicians, the coordinators. Our terminology is a coordinator. We don't have a PD nurse course. So we don't do PD nursing course also here. It is only the PD coordinator who are trained only for the peritoneal dialysis program. And in that, we have three people who are catering to our patients, who are actually almost like a 300 to 400 patients who are surviving. As I said, unfortunately, we do CAPD for the people who are very elderly, old, with the cardiac dysfunction. So that is the reason why our survival rate of peritoneal dialysis patients is very, very less. So despite that, though we do a good number of CAPDs for the past 20 years, we have been doing a good number of CAPDs, peritoneal dialysis, but our number of survival rate is very less, basically because of the kind of people in whom we start peritoneal dialysis. So every coordinator will be looking after around 150 to 200 patients. But luckily, when they are all good, so they don't have to worry about. Of which around 10 to 15 patients will be sick always. So there's a scenario when we are supposed to improve our number of peritoneal dialysis coordinators. But as such in India, nowhere, we don't have such a program of PD nurse training program. These are called PD coordinators.
他就是我们金老师的意见的话，问题的话呢，就是说我们腹透的护士是和病人是怎么样的一个配比，然后怎么样这个就是培训病人的是一对一的培训啊，还是一对多的培训啊，在哪里培训啊？病房里面还是门诊啊，还是什么？然后那么他这边呢是说，其实他们这边呢就是说跟我们的体制还是不完全一样，没有这个腹透护士的这样一个概念，但是他们呢有这个腹透的叫协调员。那么主要的工作呢，就是说，其实我听上去跟可能有一点点类似于我们的腹透的护士，他要是这样子，就是说，先呢会有一个就是跟这个病人的一个交流的过程。那么就是说，如果病人他愿意还是 ESRD 的时候，就会有一个交流的过程。然后说，如果说是愿意做腹透的话，那么做了腹透支管了以后，在2周之内的话，病人是在住院期间的，那么就会在等于说。就是在住院期间的话，会有冲管啊，然后教病人的一些过程。然后如果说病人急着回去的话呢，他们也会就是这些护士的话到病人家里面去，不是这些那个协调员的话到病人家里面去，就是进行一个培训，等于说。然后如果有什么问题的话呢，也是这些协调员到家里面去把这些病人 就是先看一下有什么情况，然后如果需要的话再带到医院里面来。然后他是说就是说但是他们这个好像这个比例的话还是蛮高的，基本上是一个这样的协调员要对100多个病人。然后，而且呢，其实就是说这些病人的话，情况通常都是很差的，这个 CVD 的事件是非常的多的，而且比这个他的整个的这个情况的话，是要比整体的 ESRD 的病人更差，因为他都是相对比较差的病人，心血管情况不好的病人，然后才做腹透的。所以其实每个时间段基本上这100多个病人，可能有10%左右的病人都是处于在医院当中的一个状态。这也是它就是整个的这个腹透的数字很难上去，然后生存率时间都不是特别好的一个原因。
Good afternoon, Professor Roger. I have a small question for you. I want to know how many peritoneal dialysis patients use the auto peritoneal machine in your center, and I want to know how about your opinion about auto peritoneal dialysis machine used in our patients, and it's still free in your country, or patients should pay for the machine or the dialysis fluid?
Yes,
Thank you.
We have automated peritoneal dialysis patients also, but we don't really advise to each and everything because it is expensive. It is expensive, and the government will not provide that free of cost to the people. So the bags can be free, but not the machine. So machine they are supposed to purchase, and the government will not give the bags which are used for the sake of machine. So they have to do only manual exchanges. Manual exchanges only they can do. So because of that, not many patients would go for automated peritoneal dialysis, APD. But we have a good number of APD patients also. Every year we take around 15 to 20 patients under APD. Rest of all the patients will be doing manual exchanges only. So because it's very expensive in our country, and it comes to around 4 lakh rupees. 4 lakh is around how much it will be? 400,000, 500,000. Yes, 500,000. 500,000 dollars wise? $10,000. 10,000. It comes to around $10,000. $10,000.
那个就是问题的话是这个 APD 到底有多少人在用？然后这 APD 的话是不是也是免费的？那么他回答呢说这个 APD 的话不是免费的，而且那个因为那个液体的话免费的那个液体的话是只能就是手工做的，所以它那个就是如果你做 APD 的话，等于说那个机器和那个液体的话都是要自费的。然后好像他说多少千的不知道。是美金还是什么？反正就是很贵吧，就是不知道是美金还是，反正就是挺贵的，就是所以。
Because time is limited, the meeting is coming to the end. Please allow me to make a closing speech to the conference. Distinguished guests and all friends, today we have successfully held Renji Hospital, Shanghai Jiaotong University School of Medicine, Nizam's Institute of Medicine Science, first conference of 1-to-1 project. Thanks for your participation and support. This conference provides a good start and will promote academic exchange between China and India. Renji Hospital and the Nizam's Institute of Medical Science through high quality academic activities. It has built up a wonderful foundation of our cooperation in the very near future. It will also promote our academic exchange in the field of blood purification, basic and clinical research of CKD and ESRD. Finally, in the upcoming of 2021, I wish all of you a happy new year. Thank you.
Thank you all for attending today's conference. Professor Sri Bhushan Raju, thank you for attendance. I think this is the end of today's conference. And I also would like to ask you, what is the suitable time for you for our next webinar, do you think?
Time will be probably our afternoon hours, but we need to really check it. It's between around 2 o'clock to 5 o'clock, 2 p.m. to 5 p.m. and any other day is okay for us. But the Indian time of 2 to 5 p.m. Anyhow, we'll cross-check with the timings between which is suitable to your hospital and our hospital, and based on that, we can start out a program.
Okay. So what do you think is the suitable date? Maybe January, February?
Yes. January, last week of January.
Last week of January.
Yes.
Okay. Let me ask the experts from our side. 下一次的话，我们如果在1月份最后一个星期做我们的这个 webinar， 您觉得可以吗？就是我们下一次的这个对交流会。Okay, so Professor Sri Bhushan Raju, so because February we will have the Spring Festival, and it's a very big holiday in China, and we would like to know if it's okay for us to have the next webinar in March.
Okay, no problem, absolutely.
Okay, great. Okay,
yes.
that would be great. Thank you for the understanding.
Thank you.
Okay, thank you very much for your attendance today. Thank you. Have a nice day.
Thank you and namaste. Thank you.
Have a nice day. Bye.
Bye-bye.
谢谢各位的参与。